I'm happy to introduce Suzanne Stevens, who is the Program Manager for the Expanding Testing Initiative of the Florida Department of Health. She also coordinates the Florida Caribbean AIDS Education Training Center, Center for Disease Control, HIV Testing Initiative, and Medical Case Management training programs, and serves as a case management expert for our Florida Caribbean AETC Project ECHO program. Ms. Stevens has spent the last 10 years as a health services and facilities consultant with the Florida Department of Health, HIV/AIDS, and Hepatitis Section. She provides technical assistance throughout the state of Florida as it relates to medical case management and core program eligibility requirements for individuals living with HIV and AIDS. Her vast experience also includes implementation of Medicaid and Medicare program changes, implementation of service contracts, and the development and rollout of statewide policies and procedures. Previously, she worked for 10 years as the Director of Client Services for an AIDS service organization, and she has extensive experience in both providing and overseeing case management and direct clinical services. It's a real pleasure to introduce Suzanne to us, and Suzanne, I will turn it over to you, noting that you have no disclosures.
Thank you so much, Dr. Beal. I appreciate it, and welcome to today's session, everybody. I wanted to start by going over today's session objectives, and upon completion of this program, you should be able to describe the epidemiology of HIV/AIDS in the U.S. and Florida, identify changes to the HIV testing law in Florida, recognize the importance of routine HIV testing, discuss important aspects of third-party testing, and discuss the roles of pre-exposure prophylaxis, PrEP, or non-occupational post-exposure prophylaxis, otherwise known as NPEP, and HIV prevention. Okay, we're going to start with discussing a little bit about the U.S. and Florida epidemiology. So let's start by talking about the HIV epidemic on a national level. In the United States, the estimated rate of diagnosis of HIV infection among adults and adolescents was 18 per 100,000 population in 2013. For Florida, you can see the rate of diagnosis is much higher than the national average at a rate of 32.1. In 2013, of the 38,475 males diagnosed with HIV, 41% were Black, 30% were white, 24% Hispanic. Approximately 2% each were males of multiple race and Asian, and less than 1% were either American Indian or Pacific Islander. And of the 9,479 females diagnosed with HIV infections, the percentages were 62% for Black, 17% for Hispanic, and 17% for white. Approximately 2% each were females of multiple races and Asian, and 1% American Indian and less than 1% Pacific Islander. In 2013, an estimated 65% of all diagnosed infections were attributed to male-to-male sexual contact. An estimated 17% were attributed to heterosexual contact for females and 8% for males. And an estimated 4% were attributed to injection drug users for males and 2% for females. Approximately 3% were attributed to male-to-male sexual contact and injection drug use, and less than 1% were attributed to other transmission categories. This chart displays the percentages of diagnosis of HIV infection by age group for 2013 in the United States. So of the 47,165 diagnoses of HIV infection, an estimated 30% were among the age range of 25 to 34, 21% between the ages of 13 and 24, and 35 and 44, 18% among 45 to 54, and 10% among persons aged 55 and older. So now let's talk a little bit about Florida specifically. Florida currently ranks second in cumulative number of HIV cases and third in AIDS cases. The Florida Department of Health estimates 126,000 people are living with HIV. As you can see from this chart, of the 67 Florida counties, the rates of people living with HIV are highest among the middle and south part of Florida. However, there are still many counties in the Panhandle and the East region with high rates of infection. These areas, particularly the Panhandle, tend to have less funding for testing and treatment. Also of significance is the fact that Florida leads all states with the highest number of newly diagnosed HIV infection cases in 2013, followed by California, Texas, New York, and Georgia. Additionally, 2 of Florida's cities that fall under the eligible metropolitan statistical areas, or EMAs, which are Miami and Fort Lauderdale, had the highest HIV infection case rates diagnosed in the country. There are some small differences and a few substance differences between the proportional distributions of population living with HIV infection in Florida compared to the U.S. as a whole. As noted in this table, Florida has a larger proportion of women at 29% compared to 25% for the U.S. And by race and ethnicity, Florida has a larger portion of blacks, 48%, compared to the 44% in the U.S. By mode of exposure, Florida has a smaller portion of MSM and IDU. However, Florida has a larger portion of cases with heterosexual contact, 38% versus the 26% for U.S. And by age group, the U.S. has a larger proportion of persons living with HIV older than 50, 44% versus 35%, which is not to be unexpected considering that we're a state where there are a lot of retirees that move here. Underlying factors are very important for clarifying why there are racial and ethnic disparities while reducing stigma. If people are diagnosed late with HIV, whether they are black, white, or Hispanic, there is more time to spread the infection and less time to get on medications that prevent progression of disease and suppress transmission. If they are diagnosed late with AIDS, they are more likely to show up in the death statistics. And not all of those who have been diagnosed choose to seek care. Stigma and denial, including fear of disclosure of HIV-positive status, can have a major impact on diagnosis, treatment, and risk reduction. Discrimination and homophobia include fear of disclosure of being an injected drug user or a man who has sex with men. And HIV complacency includes a tendency to discount the risk and personal burden of HIV/AIDS because there seems to be such good treatment for it and overlooking the adverse side effects of the medication. We need to keep in mind that AIDS still remains a fatal disease with no cure. Among the risk factors for male and female HIV infection, men who have sex with men is the most common risk factor at 77%, while females was a heterosexual contact at 91%. The age distribution in Florida for HIV infection in 2013 was highest among those between the ages of 20 and 29, followed by ages 40 to 49. Ages 30 to 39 and 50 and above had the same distribution. So to end a little bit about what occurred in Florida, during the year of 2014, there were 6 HIV perinatally infected babies born in 2014, which was as of March 2015. This is a 95% decrease from the 110 perinatally infected babies born in Florida in 1993, which was the peak year. Over 410,000 HIV tests were conducted in Florida publicly funded sites, including over 280,000 rapid HIV tests. And the HIV prevention program with the Florida Department of Health funded 38 contracts with 29 community-based organizations to provide high-impact prevention interventions and strategies to HIV-infected and high-risk populations in Florida. In addition, 20 local county health departments implement evidence-based prevention interventions, both HIV-infected and high-risk individuals. So now that we've discussed a little bit about the epidemiology for the U.S. and Florida, let's talk a little bit about the Florida law that changed recently. So a bill passed, House Bill 321 passed by the Florida legislature in May, became law July 1, 2015. The law takes Florida a step closer to removing the stigma of HIV by increasing HIV testing and making it more routine part of care in our state. The change in the law amends 381.004 Florida statute, removing the requirement for informed consent prior to HIV testing in healthcare settings. With this change in statute, a patient must be notified that they will be tested for HIV, and they have the right to decline testing, or what we call opt-out, and they must inform the provider that they do not want to be tested. Notification of the test can be oral or in writing, and if the patient opts out, that must be noted in the patient's medical record. In a non-healthcare setting, such as a community-based organization, informed consent is still required, but not necessarily written informed consent. The requirement for written informed consent is actually established in Rule 64D-2 and the model protocol. Statute only requires that a provider shall obtain the informed consent of the person upon whom the test is to be performed. Informed consent shall be preceded by an explanation of the right to confidential treatment of information, identifying the subject of the test and the results of the test provided by law. So to be clear, that for non-healthcare settings, written consent is still established in rule versus the Florida statute. As stated earlier, it is estimated there are 126,000 individuals living with HIV in Florida, and as many as 14%, or almost 18,000, do not know that they are infected. According to the nationwide estimates by the CDC, about half of all new HIV infections are transmitted by people who don't know they are infected, and many of them are newly infected themselves. Routine testing helps to prevent new infections through awareness and allow newly infected individuals to receive early treatment, which suppresses viral replication. This improves the lives of those newly infected individuals while reducing the chance of transmission of the virus to others, which is a good public health strategy. So now we're going to move on to a little bit about the importance of routine HIV testing as a whole. The CDC estimates that of the 1.2 million people living with HIV in the United States, nearly 1 in 7, or more than 168,000 individuals, do not know they are infected. Because many new infections are transmitted by people who do not know they are infected, undiagnosed infection remains a significant factor fueling the HIV epidemic. However, HIV testing has never been quicker or easier than it is today, and more people have been tested than ever before. But fear and misperceptions can still keep people from finding out about their HIV status. Many people, even those who engage in high-risk behaviors, do not get tested because they do not believe they are at risk for HIV. Others misunderstand the testing process or don't realize that rapid HIV testing can be done with a simple cheek swab or finger prick and provide results in as little as 20 minutes. Some are concerned that other people will find out that they've been tested or that they're seeking testing, although testing is completely confidential. And some avoid testing simply because they're afraid to find out if they're HIV positive. Today, more than half of American adults have not yet been tested, and late diagnosis of HIV still remains common. So who should be tested? Everyone ages 13 to 65. The CDC recommends screening everyone from 13 to 64, and the U.S. Preventive Services Task Force recommends ages 15 to 65, or younger if somebody is participating in risky behaviors. In April of 2013, the U.S. Preventive Services Task Force upgraded from grade C to grade A recommendations to screen for HIV infection. In the past, a barrier for HIV testing has been cost. However, in combination with the new recommendation by the U.S. Preventive Services Task Force, in strong support of routine testing, and with the Affordable Care Act, there is more coverage provided for HIV testing through various payers, including Medicaid, Medicare, and private insurance. Additionally, Florida statute also requires all pregnant women to be tested in the first and third trimester unless the patient refuses. And all pregnant women who present in labor with an unknown HIV status must also be tested unless they refuse. So this graph illustrates how HIV testing can result in important outcomes of improvement in quality of life and survival for HIV patients, as well as prevention of new HIV infection in others. It all starts with the identification of HIV patients via routine testing. Early diagnosis through routine testing can mean survival and quality of life for people with HIV. This slide shows the continuum of care, starting with those unaware of their infection, those that need to be tested and identified, through the spectrum to fully engaged in care. Part of prevention is identifying those who are infected with HIV and unaware and linking them to care. Persons identified early in their diagnosis can help prevent the spread of HIV. Nationally, the trends in HIV infection during the last 10 years have shown a decrease in HIV diagnosis rates, but overall the increase is attributed to MSM. So this graph shows the MSM diagnosis from 2002 to 2011. And as you can see, there is a significant increase at 132.5% of MSM between ages 13 to 24, while those between 35 and 44 have declined, and then there is a slight increase of those over 55. And this can be an indication of medical providers not being comfortable talking to an older population or to the youth about HIV because they may not determine these age groups at risk. And this also reiterates the importance of implementing routine HIV testing rather than risk-based testing in order to help medical providers identify those who they may not be comfortable testing. As stated earlier, according to the national estimates by the CDC, about half of all new HIV infections are transmitted by people who don't know they're infected, and many of them are newly infected themselves. Routine testing helps to prevent new HIV infections through awareness and allows newly infected individuals to receive early treatment, which suppresses viral replication in the blood. This improves the lives of those newly infected individuals while reducing the chance of transmitting the virus to others, which again is another good public health strategy. This chart here shows the number of tests conducted in Florida starting in 1985 with 6,156 through 2004 with 412,307, and that's the red line that you see going up. The blue line that you see is the percentage of HIV positives during the same time period. So in 1985 it was 22.8%, and in 2004 it was 1%. As you can see, Florida has a very aggressive testing program. So it's important to understand the Florida Continuum of Care and how it relates to prevention. The Continuum of Care was developed based on the National HIV/AIDS Strategy goals, which include reducing the number of people who become infected with HIV, increasing access to care, and improving health outcomes for people living with HIV, and reducing HIV-related health disparities. It is vital to improve engagement at every stage in a continuum of care that include HIV testing and subsequent diagnosis, linkage to HIV medical care, continuous engagement in HIV medical care, or what we call retention in care, initiation of antiretroviral therapy, and a suppressed viral load of less than 200 copies. As you can see in 2013, Florida had 102,208 HIV diagnosed persons. And of that number, 86% were linked to care, but only 55% remained in care during the 2013 year. While 91% of those people in care were on antiretroviral treatment, only 50% diagnosed were actually receiving treatment. And of those, only 35% had a suppressed viral load. This indicates several factors to consider in prevention and testing. 121,387 people in 2013 were estimated to be infected with HIV in Florida. So what this means is 19,179 people were unaware of their diagnosis and are not in care and possibly spreading the disease. Additionally, because so many people fall out of care during the year, they are most likely off of their antiretroviral treatment, and their viral load may have become higher and they may be spreading the disease as well. These people may fall back into care when they are at later stages and more sick. Prevention efforts need to continue to help identify people who have fallen out of care and get them back into care. The traditional HIV testing algorithm, the Western blot, has been part of the testing algorithm since 1989. Indeterminate Western blot can represent either an incomplete antibody response to HIV in specimens from infected persons or nonspecific reactions in uninfected persons. Most people with an initial indeterminate Western blot results who are infected with HIV-1 will develop detectable HIV antibodies within 1 month. Early diagnosis of HIV infection is important, allowing healthcare providers an opportunity to prevent further transmission of the disease and begin treatment. Studies have shown that infected persons who are aware of their HIV-positive status decrease behaviors associated with transmission. Using a fourth-generation testing technology detects the virus soon after exposure, which can allow for early treatment and prevention. Fourth-generation tests require a blood draw. They are more sensitive and can identify new infections earlier than with the third-generation test. The fourth-generation test reduces the window period to 15 to 17 days from the traditional window period of 21 to 24 days. This allows a person to be detected during the most acute infection time. and this can allow for earlier treatment so a person can live a longer and healthier life, make behavioral changes such as using condoms, or urging sex partners to be tested or have behavioral changes with partners, and lowering the viral load sooner, which lowers the risk of transmission. With earlier tests, there is more of a risk that someone can fall through the cracks because the test cannot predict a recent infection. Benefits of the new testing algorithm, testing technology, is that the fourth generation HIV-AB-AG combination assays are the only tests able to identify acute HIV-1 infection due to the ability to detect an HIV-1 P24 antigen, and there is a quick turnaround time for results. Detecting acute infection is significant because the positive patients can be diagnosed near their peak of viral replication when they are the most contagious. The third generation has a window period that does not allow detection of HIV during the acute infection period. So the fourth generation test also eliminates the inconclusive and indeterminate results that can be found with a Western blot, and it improves detection of HIV-2 infection. Although this has been stated several times already, it bears repeating. Approximately half of all new infections are from HIV-positive people who are unaware of their status. And the majority of people diagnosed with HIV will reduce their behaviors that result in transmission when they learn about their HIV status. Also, effective antiretroviral treatment reduces the risk of an HIV-positive individual transmitting infection regardless of behavior modification. Diagnosis and engaging patients in HIV care early has the potential to substantially decrease HIV incidence. So now we're going to move on a little bit about third-party billing for HIV. As you've already heard again, the CDC recommended changes for HIV testing in 2006, along with the insurance companies who have had to change with the new guidelines. Medicare has covered preventive services since 2008, but in a specific capacity, and the new Affordable Care Act plans cover preventive services, including testing. Each Affordable Care Act plan or private policy plan will differ and will need to be reviewed on an individual basis. So this chart shows that the states that cover routine testing under Medicaid. And as you can see, Florida does not cover routine HIV testing and only does it for pregnant women or when medically necessary. Medically necessary, as defined by Florida Medicaid, is somewhat open-ended and requires the healthcare practitioner to justify the need for a test in the patient's medical records. Medicaid is for low-income families and individuals, and it also serves elderly or those with disabilities, such as a person with an AIDS diagnosis. It also serves those who are the most disenfranchised as well. For those persons accessing Medicaid for health care coverage, routine HIV testing is an important part of overall health. Since many healthcare practitioners are not doing routine testing, a large portion of these patients may never know their status. So it's important for the state to consider policy changes in the future regarding routine testing through the Medicaid program. So this chart talks about the state's decision on Medicaid expansion. This chart shows Medicaid expansion in the states which have expanded or not. As you can see, Florida chose not to expand at this time, and although it came up again in this current session, Florida's decision was still not to expand Medicaid at this time. This impacts thousands of people in Florida who do not qualify for the Affordable Care Act but could have accessed Medicaid under the expansion and allowed them to access care and treatment, including HIV testing. It is important that Florida continue to advocate for expanded Medicaid in Florida. So there are a lot of people in the state of Florida, particularly in the southern regions of Florida, who are not going to qualify for the Affordable Care Act because you do have to have an income of 100% or higher, and many people fall below that. These people are then going to be placed on the Ryan White system or the ADAP system, or get testing through community-based organizations rather than fourth-generation testing. And that's a good thing that we have these safety nets available, but Medicaid, if they expanded in the state, could open the door to thousands of people who could then access routine care and not be part of the Ryan White system. So keep that in mind. Okay, so let's talk a little bit about changes to reimbursement. In April 2015, the Centers for Medicaid and Medicare Services issued a decision memo allowing for the billing of routine HIV testing. CMS expanded coverage in Section 210.7 of the Medicare National Coverage Determination Manual. CMS has determined that the evidence is adequate to conclude that screening for HIV infection for all individuals between the ages of 15 and 65 years, as is recommended with a grade of A by the United States Preventive Task Force, is reasonable and necessary for early detection of HIV, and is appropriate for individuals entitled to benefits under Part A or enrolled under Part B. CMS shall cover screening for HIV with the appropriate FDA-approved laboratory tests and point-of-care tests. Persons who, based on individualized physician interview and examination, were deemed to be at increased risk for HIV infection can be tested more frequently. The determination of increased risk for HIV infection is identified by the healthcare practitioner, who assesses the patient's history, which is part of the complete medical history typically done at an annual wellness visit, and considered in the development of a comprehensive prevention plan. The medical recommendation should be a reflection of the service provided. Additionally, a maximum of 3 voluntary HIV screenings of pregnant Medicare beneficiaries include that when the diagnosis of pregnancy is known, during the 3rd trimester, and at labor if ordered by the woman's clinician. One of the barriers to routine HIV testing has been the issue of cost. Billing for HIV testing, including pre- and post-test counseling, drawing blood, and the test itself, are important for entities to bill in order to bring in revenue to self-sustain HIV testing efforts. The USS Center for HIV Education and Research, under the Expanded Testing Initiative Project, has created a provider's guide to reimbursement and sustainability for HIV testing in Florida healthcare facilities, and that can be found at the link on this page. This guide is a comprehensive list of CPT codes, ICD-9, and soon-to-be ICD-10 codes, billing examples, and other materials to help healthcare facilities be able to bill and generate revenue. And one of the things that we know is that with 4th-generation testing, which is blood testing, a lot of that community-based organizations are not able to do, and therefore some of the 4th generation is being promoted by the CDC, so billing is an important factor. And I'm not saying that the CDC will no longer be doing point-of-care tests. However, they are pushing for 4th-generation testing, so those may be reduced in the future, and it's important for providers who don't currently bill to learn how to bill for these and bring in extra income and revenue for their organization. So now we're going to talk a little bit about the role of PrEP and PEP in HIV prevention. So let's talk about what PrEP is. The background for those who are unfamiliar with PrEP, the idea is for an individual who is at high risk of HIV infection, but who is not positive, would take an antiretroviral medication before exposure. The idea of providing a medication as prophylaxis against an infectious disease is well established, such as in the case of malaria prophylaxis for people traveling. PrEP should be part of a comprehensive prevention management plan, which we will discuss a little bit more in the next few slides. PrEP, or pre-exposure prophylaxis, is a common practice in which medication is provided to a healthy person in order to prevent HIV. An uninfected person who engages in high-risk behaviors is provided Truvada to prevent them from becoming infected with HIV. In July of 2012, the Food and Drug Administration approved the use of Truvada for HIV PrEP in adults who are at high risk of becoming HIV infected. Truvada is then taken daily regardless of the person's plan for sex, and it must be part of a comprehensive plan that we are discussing, and regular monitoring must occur. There are 4 basic steps for PrEP. The first is that PrEP is indicated for those that are at high risk, and that includes people such as MSM, IDU, or heterosexual contacts that are high risk. The basic eligibility is the person must be HIV negative, and that is very important that they were tested and are HIV negative before considering this. They have an adequate renal function, and they're tested for hepatitis B. follow-up is that they need to have, the drug is prescribed for daily use. There's periodic HIV testing, and there's counseling about risk reduction and behaviors. Most importantly is that PrEP is very different than antiretroviral treatment, and that lifelong therapy is not to be expected, but only for periods of highest risk. Circumstances may change where PrEP could be discontinued if a person tests HIV positive. PrEP would change to ARV therapy, and the clinician would need to reassess treatment options. And this is one of the reasons, if you're considering PrEP, that you must get routine HIV tests, because this is for people who are HIV negative. PrEP needs to be considered part of the comprehensive management of prevention. PrEP should be a component of a comprehensive HIV prevention plan, and it should include counseling on consistent and correct condom use to avoid STDs, safer sex practices and risk reduction options, frequent screening for sexually transmitted infections, and mental health or substance abuse counseling when indicated. This is an example of the PrEP agreement form. On the Truvada website, you will find resources including this PrEP agreement for both the provider and the HIV-negative patient. The form outlines the obligations of the provider about educating the patient about risks and counseling them on the risk reduction. The form outlines for the HIV-negative patient the risks, and that they are explained about the prevention strategies and safer sex practices such as condom use. Both the patient and the provider sign the agreement form. And you can find the agreement form where you can actually read it, and it's legible, at the Truvada website that's at the bottom of this page. So PrEP costs about $13,000 a year, and while most private insurance would cover PrEP, a lot of them are going to require prior authorization, particularly Florida Medicaid, Aetna, United Healthcare, maybe some of the smaller HMOs such as Capital Health Plans, or even Blue Cross Blue Shield. Private insurance may have a high copay even if they do cover PrEP. And if that's the case and the person is not able to afford it, Gilead, who provides Truvada, does have a copay assistance program. And then for those who have no health insurance at all, Truvada for PrEP medication assistance program is also available. But keep in mind, if they're going to do this, there is a lot of paperwork and stuff that you must do up front before you are on PrEP. The Florida Medicaid, again, does cover PrEP, but there is a prior authorization form that can be found at this link on this form, and it looks like this. The second page of this form, you do have to do an HIV diagnosis verification, and then you also have to have a detailed plan for prevention or risk reduction services, such as an evaluation, counseling, condom distribution. And that plan has to be attached in the form of a progress note or medical record to the submission of the form as per the CDC guidelines. So it's not just a matter of the provider filling out a Florida Medicaid pre-authorization form, but they have to attach something showing what the comprehensive plan is. Again, just to remind you, PrEP is not meant to be long-term and not meant to be lifelong. So it is really important that if you're going to go on PrEP or talk to a patient about PrEP, that you do have a discussion about the overall risk reduction behaviors. So let's talk a little bit about the non-occupational PEP. Although the most effective way to prevent HIV transmission is to protect against exposure, non-occupational exposure, or what we call NPEP, offers the possibility of preventing HIV transmission when potential exposure to HIV has already occurred. Situations that may prompt a request for NPEP include condom slippage, breakage, or lapse in use by serodiscordant partners, unsafe needle sharing, or other episodic blood exposure to blood such as human bite. Treatment of high-risk exposure should be combined with a strong educational component that emphasizes prevention for future exposures. Additionally, sexual assault merits a special focus. Victims of sexual assault should be treated in an emergency department or similar healthcare setting where appropriate medical resources are available. There are guidelines shown in the link in this slide that address the unique considerations involved in evaluation, counseling, and support for HIV exposure resulting in sexual assault. Determining the degree of risk of HIV transmission is an important factor in guiding the patient and the clinician making the decision about NPEP. This is a list of high-risk exposures, which include the source known, or the known person HIV infected, or if they don't know their HIV status, receptive and insert of vaginal or anal intercourse, needle sharing, injuries with exposure to blood or other potentially infectious materials, needle sticks with hollow bore needles, human bites, and accidents. Other lower risks of exposure that would need to be considered would be oral vaginal contact, oral anal contact, receptive penile oral contact with or without ejaculation, and inserted penile oral contact with or without ejaculation. Factors that increase risk is if you know the source person's, if they are HIV infected with a high viral load, if there's non-intact oral mucus such as lesions or wounds, blood exposure, and genital ulcer diseases or other sexually transmitted infections. You also need to evaluate the types of exposure that do not warrant NPEP, and that would be things like kissing, remote risk with open mouth and sores or bleeding gums, oral-to-oral contact without mucosal damage, human bites that do not involve blood, exposure to solid bore needles or sharps not in a recent contact with blood, and mutual masturbation without skin breakdown or blood exposure. So this shows the NPEP for HIV algorithm. And what it shows is if you're at high risk, when to start NPEP, and if you're at no risk, not to start NPEP, and if you're at low risk, based on the things that we just went over, it's going to be done on a case-by-case basis, considering all of the factors that we just discussed. So let's talk a few minutes about when the source person is available and consents to HIV testing. HIV testing using rapid technology is strongly recommended as soon as possible in order to aid in the decision-making regarding NPEP. Results from rapid testing are usually available within 60 minutes. Laboratory-based screening tests may be used if results can be available within an hour. If the test results are not immediately available, the initiation of NPEP should not be delayed pending the test results. So the source persons who are in a window period prior to seroconversion may not be identified. When the source person's screening test result is negative, but the clinician has ascertained that the person could have been exposed to HIV in the previous 6 weeks, or when the person's screening result is positive, but the confirmatory antibody is non-reactive or indeterminate, then a plasma HIV-1 RNA assay should be obtained to determine the person's HIV status. In these situations, NPEP should be initiated and continued until results of the plasma HIV-1 RNA assay are available. This resource summarizes the guidelines for the management of occupational and non-occupational exposure, including hepatitis C and hepatitis D, and it includes recommendations for pre-exposure prophylaxis for the prevention of HIV in men who have sex with men, injecting drug users, and heterosexually active adults who are at high risk of acquiring HIV. Post-exposure prophylaxis is also summarized, and this resource is intended to guide in initial decisions about PEP and PrEP. And this is a pocket card that can be found on the Florida Caribbean AETC website that is listed here. It's a very helpful resource. It's small, it's easy to use and have with you. If you are interested in obtaining one of these, you can click on the link and download or ask to order some. Another resource is the Clinician Consultant Center, which provides rapid expert consultation and advice on management of HIV/AIDS, perinatal HIV, and post-exposure prophylaxis for bloodborne pathogen exposures. The clinical consultants are HIV treatment experts, experienced physicians, clinical pharmacists, nurses, and nurse practitioners from the University of California, San Francisco. And this is a great resource, especially since it's available 7 days a week. So in summary, several things that we want to be reminded of. HIV is a serious disorder that can be diagnosed before symptoms are developed, especially with use of the fourth generation testing. It is detectable by reliable, inexpensive, and non-invasive screening tests. HIV disproportionately affects people that are likely to be without a regular source of care or have barriers to care. And infected patients can add years of life to gain if treatment is initiated early and before symptoms are developed. The costs for screening are reasonable in relation to the anticipated benefits. Also, the 2006 CDC revised recommendations for HIV testing in pregnant adults, adolescents, and pregnant women are supported by many medical groups. And although the CDC and the U.S. Preventive Services Task Force differ a little bit in their age ranges, they're still between the ages of 13 and 65 and considered grade A recommendations. Additionally, Florida statutes require that all pregnant women be tested in the first and third trimester. And now that Medicare can pay for that, this is another good reason to provide routine testing. The CDC HIV diagnostic testing algorithm that was released in 2014 for the fourth generation testing improves the ability to diagnose acute HIV infection. And it eliminates the indeterminate Western blot results. And it improves the differentiation between HIV-1 and HIV-2 and has a rapid turnaround. This is another important reason to promote the use of fourth-generation testing for acute infection and diagnosis, which again goes back to if you diagnose somebody during acute infection, get them on antiretroviral therapy, then you also are lessening the risk of people spreading the disease through prevention. Blood-based fourth-generation testing is in the future. And the state testing laws that changed this year eliminate barriers while still allowing for opt-out. Please keep in mind that while we now have this opt-out, patients still must be notified that they are going to be HIV tested, and then they choose to opt out if they want to. I believe that this will be something of a barrier that will be eliminated just like it was when we did this for pregnant women. Most people do not opt out and will choose to have the HIV test, especially if it's part of an annual or routine exam. Also, we need to keep in mind that PrEP is an underutilized tool in our toolkit, and we need to consider the use of PrEP when it is appropriate. And lastly, that NPEP needs to be readily available to anybody under the right conditions and circumstances. There are a lot of available resources with the Centers for Disease Control, also with the Florida Department of Health, who has resources on testing guidelines and training, and mobile HIV testing sites throughout the state. There are plenty of resources regarding self-learning tools. So for people who do not currently bill for HIV testing, there is a self-learning tool here, and there are others that I can share as well that help people learn how to bill for HIV testing. And again, the importance of billing for HIV testing, which is not frequently done, is to help sustain organizations by bringing in revenue. And this is something that we need to focus on a lot. And other resources that are available are with the USF Center for HIV, the USF HIV Center for Prevention website. And again, this website will take you to the resources that I showed you earlier with the pocket card and the reimbursement guide, plus other resources for individual areas. There is also the Florida Caribbean AETC.org website, which you will find numerous resources at. And lastly, the Florida HIV surveillance data. If you're not familiar with the surveillance data in your area, this is a great place to go and find out, especially if you're looking at the continuum of care, which I shared in this slide. The one in the slide presentation was for Florida, but there is a continuum of care for all of the areas individually, and it's important that you know the individual continuum of care for your area and how that fits into your prevention plan. So having discussed all of that, I would like to end today's session with any questions that you might have.
Thank you, Suzanne. Very nice job. I appreciate the information and the excellent presentation. Thank you. When you talk about community-based organizations, CBOs, what about their responsibility moving forward with billing for routine HIV testing?
Okay, well, thank you for that question. It is a little difficult for the community-based organizations, especially those who are not a federally qualified health center or a primary health care center, or even a look-alike, because if you're a standalone community-based organization, you usually don't have relationships with private insurance, Medicaid, or Medicare in order to bill. And so for community-based organizations, this can be a hard task, and many of them have been going to partnering with entities that are federally qualified health centers or clinics of some sort in order to be able to bill. I know the Florida Department of Health is currently looking at how that may happen in the future, but as of right now, a lot of them are not able to bill because they don't have those relationships or the ability to develop those relationships with private insurance, Medicaid, or Medicare. So if you are a community-based organization and you know fourth-generation testing is something that the CDC is promoting, you may want to look at your infrastructure and determine whether or not you could align with a clinic of some sort or become part of a clinic in order to help you bill and sustain for the slides. Please keep in mind the Florida Department of Health is going to continue to provide testing kits, but those may decline in the future with the reliance of people being able to bill to sustain their own programs.
Very good. Expand on that a bit. If someone in a clinical setting or in a CBO would want to learn more about billing, promoting routine HIV testing in healthcare settings, what are the resources available?
So there are actually several resources available to help you learn how to bill for HIV. And it's not as complicated, believe it or not, as it sounds. It's an issue of most people have just chosen not to bill. The resource that we provided earlier in the slide that is on the USF Center Prevention website has a lot of examples of how to bill, both with private, Medicaid, and Medicare. And that includes the use of the CPT codes, ICD-9, which will become ICD-10 codes this year. And in there are a lot of links to resources where you can actually go in and they will provide you some interactive tools to learn how to bill. So that resource is something that I would encourage everybody to download. It is certainly something that you can easily go to. You can download it. We are in the process of revising that in order to update the current Medicare changes, the changes to the testing law, and some Q&A that we will put in there and other examples. And we will put additional resources in there for people to use as well.
Wonderful. Thank you. And in your travels and your experiences across the state of Florida, do you have any comments about what we can do to help promote routine HIV testing in the healthcare setting?
Actually, I do, and this is something that I would encourage all of you to do, especially those of you in community-based organizations that work with a lot of the private physicians in the community, either by referring your patients there or linking them there, working with them in whatever the capacities are. If you ask a lot of the offices if they provide routine HIV testing, some of them will say yes, but if you ask them what that means to them, what you often find is that they are still doing risk-based testing. So don't assume that somebody is doing routine HIV testing or that they know what the changes in the CDC guidelines were, even though they've been out since 2006. What I've found is that, especially going to medical conferences and doing exhibits, is that many of the physicians aren't aware of the change and the guidelines, even though they've been out for a while, and really are timid about providing routine HIV testing. People are still uncomfortable talking to youth, talking to those who might be older, but all of these populations are people who need to be tested, and this is why it's important to do routine HIV testing, so that we get people more comfortable talking about it. We assume because it's a physician that they are comfortable talking about it, but don't assume that because many of them are not. And we would really like you as people in the community that have relationships to share the CDC or the U.S. Preventive Task Force guidelines and to promote the use of routine testing, even though you're usually oftentimes seeing people who are already positive. Keep in mind that these doctors are working with patients who haven't been tested, and again, half of America has not been tested for HIV, and we still need to identify these people, and it's possible to do so. So your own promotion within your community with your providers is still very important.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and PreExposure Prophylaxis, Non-Occupational Post-Exposure Prophylaxis, and Occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.